And we are live. Dr. Pauline Maki, thank you so much for joining us all the way from Chicago this morning and making time in what I can imagine must be for you an awfully hectic schedule, because you are indeed an incredibly busy woman.
It's a busy time for those of us in the menopause field. Thankfully, it's about time, right?
Well, that's true. There are pluses and minuses to these things. Before we get to those things, let me give everybody a quick, brief introduction of who you are. And it's very hard to make this brief because you've got a serious number of degrees here. As I said, but I see it almost looks like hoarding. There's a lot of work that you've been doing over the last few years. You are a professor of psychiatry and psychology, obstetrics, and I can't even talk now, obstetrics and gynecology at the University of Illinois, Chicago. You're also a lead of the National Institutes of Health funded research program on women, cognition, dementia and mood, with a focus on menopause and hormone therapy. And you're currently looking at vasomotor symptoms, which is very interesting, and their effect on the brain. You're also a past president of the North American Menopause Society, now the Menopause Society, a trustee of the International Menopause Society, as well as being a director of the Women's Mental Health Research Program and a senior director of research at the Centre for Research on Women and Gender. You've published more than 320 papers, which is a lot of writing, including being one of the authors on the newly released IMS white paper on menopause and HRT in the lead up to World Menopause Day. But before we get to that, psychiatry, psychology, gynecology and obstetrics, how did you get to mix those two together?
You know, it's interesting, Fiona. When I was in graduate school, I became very interested in Alzheimer's disease. My maternal grandmother had Alzheimer's disease, and I wanted to understand, is there something about being female that makes us more vulnerable to this? Imagine that at the time that I began studying menopause hormone therapy in the brain, I could read everything. Like I knew everything because the literature was so limited in terms of its scope. And so I became very interested in this question about women and Alzheimer's disease. And I wanted to know in particular whether or not there was a signal for hormone therapy and a potential either benefit or drawback in that. And to understand that, I needed to go into other disciplines. Really needed to understand menopause as an experience that women went through. What is the physiology of menopause? Is it just the loss of estrogen? I think too often we focus on treating the loss of estrogen instead of thinking about the constellation of impacts of menopause that can affect our brain and our cognition and our moods and our well-being. And so it's really what we call a multidisciplinary field. You need to know the science of the menopause. You need to know neuroscience. It's not just enough to be within one discipline and address all of the questions that we as women have when we transition through this space.
Gosh, you're absolutely right, because it is incredibly complex, isn't it? And that's the this complexity has also led, it seems, to an awful lot of claims and confusion at this particular moment in time. So let me take you back to your IMS white paper for a beginning. At the moment, we do appear to be in a particularly polarized world when it comes to menopause. We've had papers published saying it's over-medicalized. We've had rebuttals coming back saying it's not over-medicalized. We've got claims that HRT, or I would just call it for the sake of everybody here at the moment, hormone therapy, that it can do miraculous things for brains and hearts and all of these kinds of things. So why has the IMS now decided, because this has been quite a long time coming, that it needs to tackle these controversies, and which are the key ones that you think do need tackling?
Yeah, thank you for the question. I think all of us in the field of menopause are united with the goal of improving the well-being of women, and we have to applaud that. We're paying attention to it, right? I think where there has been disagreement is what are the solutions, and how do you decide whether to recommend something as a solution for a particular menopause issue, in my case, brain fog. Fiona, when I started out in the field, I was really launched quite rapidly because I discovered where estrogen receptors were in the brain of menopausal women and how hormone therapy altered that. And I'll tell you, I was, quote, a believer. I thought, oh, universally, it looks as though the loss of estrogen alters memory, it alters brain function and the like. But then the randomized trial data came out. And it wasn't just one study, it wasn't just two studies, it was 4 large-scale randomized trials that showed that in women without significant hot flashes, hormone therapy had no effect on memory. None, zero, zip. So I had to accept those data and say, you know what, I was wrong. I based it on the observational data. I thought it would have an effect, and it didn't. So I was wrong about this universal recommendation for hormone therapy. And so my change of heart came based on randomized trials. And what I'm seeing now is people are following that same kind of thinking that I did, which is, oh, look it, we have all of these observational studies now. And we think that that can guide decision making, when the true test, if you will, is whether or not in a randomized trial this works for a particular condition. And I think it's important to know what we know, and equally important, what we don't know. So we don't know, for example, if hormone therapy improves memory and cognition in women with hot flashes. Is that crazy? I mean, it's crazy. It's the very indication for which we give hormone therapy. So I feel very comfortable from my research saying, hey, if you have hot flashes, yeah, you should take hormone therapy. It's very good for that. It's the gold standard. If you have contraindications, we have other things for you. But yeah, you should take it, and you might get a bounce back in your memory. But because of those randomized trials, I say, you shouldn't take it because you think it's going to improve your brain fog, at least not in the early postmenopausal period. So what the IMS has done is it's looked at that long kind of historical movement in the transition from these observational studies where you just look at hormone users and non-users and compare their health, and then look at the randomized trial data, see if it agrees with that, and then as scientists, as providers, adjust our opinions accordingly. And we felt that it was important to remind people of this journey that we've been through, of the science that backs the IMS guidelines, because there's so much chatter, so much social media right now that's giving women recommendations that kind of, in my opinion, take us back.
See, this is an interesting one, isn't it? Because as you say, now we have this sort of, we're in this society at the moment where we have a lot of very popular people with very powerful opinions put very powerfully on social media, who would probably say to you, hang on a second, Pauline, you know, for God's sake, we've got these randomized, we've got these studies over here of, you know, nearly 1 million people, observational data from insurance that show that these people who are on hormone therapy have less dementia. Surely all roads are leading to Rome, and you're just being a stick in the mud, and you're just not moving with what we're seeing when these women come into us every day and say, my cognition's better, I'm functioning much better. So why is there this disconnect between what we're seeing?
Yeah, firstly, let me say that it is not the case that the large observational databases in recent years suggest that hormone therapy is beneficial for Alzheimer's disease. In fact, it's exactly, and I mean exactly the opposite. The 4 most recent large-scale studies have actually shown a significant increased risk of Alzheimer's disease in women who've used hormone therapy. And it doesn't matter what the formulation is. It doesn't matter what the route of administration is. It doesn't matter what estrogen or progesterone you choose. The signal is there. So I think there can be a selectivity. And even when I see some of this pro-estrogen for cognition stances, when these stances are taken, I'll see them select data from those studies that isn't the data that was in the abstract. It isn't the ones that the people who wrote the papers thought was the most important one. It's kind of, they go in and they select something that looks a little bit better. So I think we need to be as objective as possible when we make, these decisions about what to recommend to women. And I think women do feel better on hormone therapy. And I think their cognition may very well feel better, but it's probably because they're having fewer hot flashes, they're sleeping better, and maybe their mood's a little bit better because of all of that. What we do know is, absent those symptoms, there's zero evidence to suggest it's beneficial.
The other thing that we look at all-cause mortality. Obviously, then, this is making a difference. If there are less people dying from dementia, then surely it's making a difference.
Yeah, so let's talk about that dementia study. I was so pleased to see that study, because here's my big picture view, Fiona. This is my philosophy about hormone therapy, and it's quite easy. If you have vasomotor symptoms, which many women do well into their 60s and some even into their 70s, our data show that we think those are toxic, almost like having hypertension, that you need to treat those hot flashes. And nothing does that better than hormone therapy, right? So that's what we want to do. We want to treat those hot flashes. We want to improve our sleep, because when we have those hot flashes, we wake up, right? And when we're sleep deprived, day after day, week after week, month after month, year after year, we're going to feel better when our sleep's improved, right? And all of that is critical for women's health. So if we look at that aspect of hormone therapy, I completely believe that that's what it's doing. I don't think the loss of estrogen itself is triggering a dementia in women. Let's think about that logically, Fiona. If that was the case, let's look at a group of 70-year-old women. What percentage of them have been through this loss of estrogen?
100%.
100%. And what proportion of those women will get demented? About 20. And what proportion of men will? About 19. So really, is there this cause-effect issue with the loss of estrogen and Alzheimer's disease? It can't be that simple. The data just don't bear it out. So who are the vulnerable women? Who do we need to think about menopause-related issues? In my mind, it's the many, many, many women who've gone untreated for the menopause symptoms. So I still adhere to the belief that we must increase the uptake of hormone therapy for symptomatic women. Absolutely 100% agree with that, because I think it does protect their brain. Now let's get to that question that you had about the 18-year, your audience won't know this, but after we got that black box warning in hormone therapy saying, don't take this, it causes dementia. That was in a study where they used a specific formulation of estrogen plus progesterone called conjugated equine estrogen and medroxyprogesterone acetate. I'm going into these details because other formulations don't show that harm. So it seems to be specific to that formulation. But that particular formulation doubled the risk of all-cause dementia in women over age 65. So that's what led to this black box warning. Then 18 years later, there's a study that comes out that included some of the women in that same cohort study, but there were 27,000 women, and it said, wow, there's a 26% reduced risk of Alzheimer's disease in the women who take the estrogen alone. Wow. Okay, so that's exciting news. Something prevented dementia. But the question here, Fiona, is how do you translate that epidemiological study to my decision-making with a woman right in front of me? How do I do that? And the way that we do that is through the calculation of the number of women you would need to treat with hormone therapy to prevent one case of dementia. And if that number is low, if I only need to treat 10 women to prevent a case of dementia, then that suggests, okay, maybe this should change medical practice. You'd need to treat 2,004 women to prevent one case of dementia. Let me repeat that. Using those data, you'd need to treat 2,004 women. So that means 2,003 women took it without getting any benefit. but potentially accumulating those rare harms, and they are rare, those rare harms that come with hormone therapy use. So the increased risk of breast cancer later in life, for example, with combination formulations of hormone therapy. Rare, but there. So yes, we have to translate the data for our patients, because if I tell you hormone therapy decreases the risk of Alzheimer's disease by 26%, you're going to think, oh, my own risk is decreased by 26%. But that's not how that finding needs to be applied in the clinical setting.
Okay, so where is this got lost in translation then? Because that is a quite significant loss in translation.
Yes, I think the beautiful thing
down here, they say, well, this is depressing, but it may not necessarily be depressing.
No, I think I don't find it depressing at all. I am so excited about the idea that women are speaking about their needs. They're advocating for themselves. They're demanding answers. They're demanding answers from their providers, from researchers like me, from policymakers. It is wonderful. Everybody wants the answers, and we want oftentimes easy answers. I mean, if I had to take a pill, if I could take a pill instead of sleep hygiene, oh, I'm in, right? I mean, I want to take a pill to sleep better, but that's not the best way to foster sleep, and therefore not the best way to foster brain health. So I think there's the demand has not met the ability or the knowledge base of people involved to meet that. And I become suspect of people who are making a lot of money on the solutions that they're selling. Now, I live in the States, capitalism is rampant, but if I'm getting my news from somebody who's selling me things as an influencer and then is recommending things after things after things, is this really an unbiased kind of approach? Does what they say align with what medical societies say? And so that's kind of a clue that I take. But I think, social media requires an active presence. You have to be talking.
Yes,
right?
you do.
You have to be saying new things. You have to be saying new, shiny things. There's nothing new and shiny with telling women, you know what, hormone therapy is really good for hot flashes. And if your hot flashes are treated, you might sleep better. It's also very good for your bones, very good for genitourinary syndrome of the menopause. But that doesn't sell a social media influencer's time. You need to shine it up a bit. And so it's a challenge. It's a challenge.
It is, but it does then throw back the challenge to people like you in the International Menopause Society, now the Menopause Society, and here at the BMS, because but once the horse is bolted, once somebody has come out and said, well, you know what, HRT is going to prevent this. If it's good for the brain, I mean, it's good for the heart, it's got to be good for the brain. It makes complete logical sense. You should be on HRT. It's got to prevent whatever else it is. Then you're coming out 3 or 4 years later and going, whoa, hang on a second. You're in that sort of situation where people are going to go, well, hang on a second. I've been told by this very powerful, trustworthy person who I thought was trustworthy that this is the way it is. You're now putting a kibosh on that. Who do I believe? I'm confused. Yeah. Is it just because because you don't, you're just not seeing what I think the word that is often used, or the phrase that's often used these days, is the lived experience of the patient that they see in front of them. And that's a very kind of powerful argument. So how then, if you're sort of sitting with these societies and you've got these, waves of evidence, how do you react as quickly to these challenges as the powerful influencer does?
The quick answer is we don't. We don't have the power that we need against social media. And what it requires really is the training of our workforce, our medical delivery workforce, in evidence-based menopause care, so that women can go into their regular doctor and get the kind of care for their menopause symptoms that they get for hypertension and for, elevated cholesterol levels. But what's happening is when they're going into their provider's office, their providers can't speak about the data, that we miss generations of training. And so it's part of the fallout from the WHI, but that's where women should be getting their information about menopause. You know, I give a lot of talks because I dedicated my life's work to helping women maintain their brain health as they age. It's all in self-interest, Fiona. All I want is a healthy brain as I age, right? That's what we want. But, you know, at the end of these talks, people will say, okay, and what's your social media handle? And I give the same response every time. I say, listen, I don't have a social media handle. If my work makes a difference for the care of women, then medical societies will select my research articles and say, this is something now that we can act upon as medical providers. I'm not the spokesperson for my own research. I create evidence, I put it into the scientific publications, and then people decide, they gather together, they vet my research and decide whether or not to change medical practice based on that. That, in my view, is the way that we get objective. You know, it's not about me kind of care for the menopausal woman. And the lived experience is something I live, right? I've been through it. I've written editorials about what, you know, how my brain changed as I went through menopause. And we need to believe women. At the same time, you know, I'll tell you, I hooked myself up to my hot flash monitors because I was validating them for a study. So I had 3 different hot flash monitors on. And my research assistant said, Pauline, you said you've been tired lately, right? I said, yeah, I've been tired lately. And she said, you had 3 hot flashes last night. I said, what? I had 3 hot flashes last night? I didn't know. Right? And this is my expertise. And I share that with women because you can both have hot flashes that you don't detect, and you can also believe that you're on treatments and your hot flashes are getting better, and they don't, because we don't always sense what's going on from a hot flash perspective. And we know from randomized trials that if you give women or men with prostate cancer, men too, a placebo pill, they will report on average 35 to 50% fewer hot flashes, but it's doing nothing. And so when women say they're feeling better, some of it is the expectations of feeling better and the belief that you have in the medical system. And the challenge with that is that our work shows that it doesn't matter if you think you're having the hot flashes. It's the hot flashes we can measure, regardless of whether you detect them, that are associated with problems with brain health. So we need to give women real solutions for their hot flashes. Real solutions, not placebos, not supplements, not, that's what we need. We need real solutions.
Yeah, it's an interesting one, isn't it? Because like you, I have a vested interest in this one. My mother was diagnosed with early onset Alzheimer's at 56, dead by 64. I'm now 60.
Oh,
so you can imagine every time every time I forget a word, well, that's it. That's the end. So, theory, in the interests of open declaration, I am on HRT, and I am fingers crossed that hopefully it will be found to actually help at some stage. But I guess this brings back to the is it because the vasomotor symptoms destroy sleep? Is it the vasomotor? Because we've had calls now for vasomotor symptoms themselves to be regarded as an independent risk factor for heart disease. Should there be a similar thing for vasomotor symptoms and brain health? And also, what does it mean then to people of African American descent, people of colour, who have way worse vasomotor symptoms than women, and 25%, I think, increased risk of dementia.
Exactly.
How do we get across to people?
Exactly. That I'm so glad you brought up the health inequities in this area, particularly around hot flashes, which is a main focus of our work at the University of Illinois at Chicago, where we study primarily Black and Latinos and their experience of menopause and what it means for their brain health. So this is a critical issue. We do know that at minimum, women who have persistent hot flashes are at increased risk for cardiovascular events, cardiovascular disease, and cognitive decline, right? What we don't know is whether or not that's causal. because you can imagine that the same third factor, say a poor vasculature, could cause both worse hot flashes and a later risk of heart disease. In the case of cognition, we do have a proof of concept that if you treat the hot flashes, memory improves. Because we did a randomized trial of a non-hormonal intervention called stellate ganglion blockade. And the reason I used it is because it's not known to improve cognition generally, but it treats hot flashes. And we asked the question, if you took away the hot flashes, did memory get better? And the good news is it did. So some evidence of cause and effect for the hot flashes in memory. We don't yet have the same thing for the cardiovascular field, but the theory is similar, right? So we at least know that the women who are having these symptoms need to engage in health behaviors and perhaps pharmacological interventions to lower the risk of heart disease later on, to lower the risk of dementia. And in your case, I would actually say in your case, I would refer you to a Paganini, Hill, and Henderson study from 25 years ago that showed that for early onset Alzheimer's disease, there is in fact a beneficial signal. And that was the Mirage study by Dr. Henderson. But interestingly, it was only the women who were, it was only dementia between the ages of 50 and 59 that was protected. The later dementias weren't. And I think it's because of this, you need it to treat these hot flashes. And that's what the hormone therapy is doing. It's protecting you from this other factor that can elevate your risk, right?
It's an interesting, a couple of questions over here. People say, well, should I not take it then if there is a bit of, with a history of early onset Alzheimer's? I had a couple of questions over there. So at least that's relieved that one, that there may actually be some hope there. In some ways, actually, do you think it's going to be end up like, being like the sleep apnea, an analogy?
Yes.
Yeah.
That's a beautiful analogy. I think so. I think so, yes. And you know what's interesting is these hot flashes with my dear friend and colleague, Rebecca Thurston, another giant in the field of menopause. We published a couple of papers lately that really show the associations between little stroke-like lesions in the brain called white matter hyperintensities and hot flashes. And that's exactly what you see with sleep apnea, and it's exactly what you see with hypertension. And so you take these multiple risk factors. Let's say I have a little hypertension. Let's say I have a little sleep apnea, and I have my hot flashes. And then suddenly my female brain is very vulnerable, right, to these things. And what I'd hate to see is women not engaging in the things that we do know improves our brain health, makes our brains more resilient to Alzheimer's disease, and instead to take a pill that at best is neutral, right? At least if they don't have symptoms, so we need to be prescribing and engaging in the activities that really work. And I fear that women check the box mentally and say, oh, I'm on hormones, I've already done the hard work for dementia, instead of exercising,
not smoking,
having a chat,
eating well.
Yes, exactly. Sleep hygiene, all that. Yeah.
Yeah, I did a post actually the other day on the 14 modifiable risk factors, and normally I get a reasonable amount of engagement on things, and this one just like virtually flatlined. It was like,
really,
nobody talked about the modifiable risk factors, which is a little bit on the sad side. But anyway, there you go.
And Fiona, that's why it's challenging to go up against these influencers, because what does it mean to me in terms of my level of excitement to say, okay, so you want me to follow the Mediterranean diet, versus somebody saying, look at this new supplement, I have ashwagandha, and look at this magical thing I have. It's a challenge.
Yeah, it absolutely is. In terms of, there are a couple of other things, I suppose, that people who go through surgical menopause, POI, early menopause, how important is hormone therapy for them?
Critically important. So there certainly is a group of women for whom hormone therapy is indicated for primary prevention of dementia. And it's that, 6 to 9% of the female population that goes through menopause early, before the ages of 50. And here we know that use of hormone therapy until the typical age of menopause completely takes away the risk that they otherwise would have for Alzheimer's disease. So you don't even need to use it lifelong. You only need to use it up until the typical age of menopause in order to have that protection. Again, I do think that if you're having symptoms, you need to treat those symptoms. And not enough women are getting the help they need for their symptoms. So it's almost like they're using it for the wrong reasons instead of the right reasons. Yeah.
Yeah, it's an interesting one too, because they had a study that that they were doing here. They launched it last year, looking at women's reproductive health from the ages of 16 to 55. And I was so incensed that they stopped at 55 that I basically took their study, modified it a little bit, and put it out there as well. You know, we often hear the people say that oh, after menopause, you know, you probably have a couple of years and your vasomotor symptoms will sort of fade out a little while after. Not according to these women.
No.
And, you know, the top on the list of their issues were brain function. Basically, the brain fog was living hell. They couldn't sleep, and the vasomotor symptoms. So does this also mean that we are at the other end of the age scale, that we need to be sort of looking at them and saying, well, hang on a second, your vasomotor symptoms really aren't under control. We've got to do something about it, whether it's hormonal or non-hormonal.
Yes, yes. And in fact, so we know that on average, women have hot flashes for 7.4 years. We know that Black women on average have them for 10 years, at least in the United States. And for Latinas, it's about 9 years. So actually, that's the median. So what does that mean to the non-expert? That means that 50% of Black women have hot flashes for more than 10 years. 50% of Black women have hot flashes for more than 10 years. So they're well in their 60s, right? And so, yes, absolutely. This is where the field is going, that we do need to treat these. And it does help with sleep. It's not enough for sleep. So, you know, a lot of us think that, oh, sleep will get better with hormone therapy. There's about 26 randomized studies, and about half of them show benefit and the other half don't. I think it depends a lot on the hot flush stage. But it turns out that 75% of the time that we have a hot flash at night, we wake up. Okay, so it does trigger awakenings, and that might lead to the impression, okay, we're waking up because of the hot flashes. Well, it turns out that most of the time we're awake when we want to be sleeping has nothing to do with the hot flash. So we need other solutions. And the evidence-based approach for that, which is critical for brain health, right? Sleep is so important for brain health. You don't need a PhD in cognitive neuroscience to know this, right? My 15-year-old knows this, you know, as she's studying for her finals. The evidence-based approach there is cognitive behavioral therapy for insomnia. It's recommended by sleep societies, and it works. It works beautifully. And there are apps to get at this. Part of it is sleep hygiene, but it's also training our bodies to sleep. So that's one of the most important things we can do. And yeah, life's unfair. We go through menopause, we just don't sleep well anymore. And sometimes it's for the rest of our lives. So we need to be proactive and address those sleep issues.
Yeah, absolutely. Coming back to you mentioned before that, you know, estrogen did show some type of improvement for some people. I've had some questions come in from some of the medical professionals basically saying, so okay, what types are there combinations of hormones that we know do better or do worse? Does it have to be a body identical progesterone or a synthetic one when it comes to those sorts of things, or estrogen alone? I mean, obviously, if you've got a uterus, you've got to have both. So how do we know what's best?
We know what's worst, and that's the combination of conjugated equine estrogen and medroxyprogesterone acetate. Now, what about conjugated equine estrogen? Well, that's the one that was associated with that 26% reduced risk of Alzheimer's disease death in the Women's Health Initiative. And it's also, and I like to point this out to the people who are like, oh, you don't want to use CEE. It's also the formulation that created the whole hypothesis that hormone therapy lowers the risk of Alzheimer's disease, because that's what was used up through the WHI. And at that point in time, the literature did show a very similar signal, a 26% reduced risk of Alzheimer's disease with that particular formulation. There's been one study that directly compared conjugated equine estrogen and a transdermal estrogen. In that study, it was in women without hot flashes. In that study, neither formulation improved memory, none. So you didn't get the kind of boost in memory that you would, say, for example, if they had randomized women to exercise or randomized women to sleep hygiene. You didn't see that in this study. And the imaging data suggested some benefit for Alzheimer's disease biomarkers in women with the genetic predisposition, but only in the transdermal estradiol arm. That being said, if you looked at the brain structure, both formulations of estrogen were associated with poorer brain volume. So, there isn't a lot of head-to-head data. So I don't think formulation matters. I think what matters, in my opinion, in the female brain, based on our research, is making sure that whatever you're taking is treating those hot flashes. And it might not even have to be estrogen. I mean, estrogen is really good for our bones and really good for, genitourinary syndrome of menopause. So there's lots of reasons to choose that. But in the women who don't want to take it or can't take it, one of these new neurokinin 3 receptor antagonist drugs would work theoretically just as well to benefit the brain, because it would take away those hot flashes, and it also improves sleep and mood.
Yeah. There you go. I just had a brain fog moment myself, which I have quite regularly. The other questions that are regularly asked about these things is there a window of opportunity like there is with the heart, that if you start within a period of time, then you'll get a greater benefit than if you started later? So what happens? Do we have a window of opportunity? What happens if you're over 60? Or the other question is what about continuing on beyond, if you've been long term? What do we know about those?
Yeah. With this idea that it's really estrogen is working to prevent symptoms that are harmful to the brain, there is a window of opportunity in that women have these symptoms more often earlier. And I think that the benefit that we're seeing sometimes with this early hormone therapy is because we're treating these events for the brain that the brain doesn't want, right? They're just not good for the brain. There is evidence, that 26% reduced risk study that we talked about, the WHI. Many people don't know that benefit was driven by women aged 70 to 79. It wasn't the younger women that were driving that lower risk of all-cause dementia. So I kind of see that could have been survival biased, right? They've already lived. It could be that some of the benefits, for example, to the heart, maybe that conferred some lower reduction. But I think this window of opportunity, at least in the early postmenopause, has to do with the treatment of symptoms. Now, Fiona, there's one huge gap, huge gap in knowledge that we need fixed in women's health. There's so many, but this is a really important one for menopause. And that is the changes in memory that occur in the menopause transition begin in the perimenopause. Okay, it's not the postmenopause. It's not like bone. You start to see this as soon as hormones start fluctuating. Now, this shouldn't really be a surprise to us if we think deeply about it, because we know that the female brain doesn't like hormonal fluctuations, right? We get depressed, anxious in the postpartum period, when we, at the end of our menstrual cycles, when hormones are in flux. And the perimenopause is a period of hormone flux. Can you imagine we don't have a randomized trial of oral contraceptives, for example, which will treat this hormonal fluctuation in the perimenopause when these memory changes are happening? We don't have any clinical trials in that space in the perimenopause when these changes are initiated. And studies show that many women bounce right back in the postmenopause. So the window might actually be early. It might be in the perimenopause that we really need to prevent this. We know that's when we're vulnerable for mood problems, right? So that's when we can get depressed as well. And there's a special female brain vulnerability, not for all of us, certainly not for all of us, but for a subset that happens when these hormones fluctuate.
You mentioned before, actually, but I'll come back to those things in a second ago, but just where I was actually going to start before was actually saying, so what exactly does happen to the brain? Because you've done this neuroimaging as well. And we hear a lot about the brain receptors, screaming out for estrogen and basically saying, bring it on, bring it on, bring it on. So, and what really happens? Do we know, just basically tell us what's going on and what happens and how long does it last for? Do we recover?
We don't know.
Okay.
Let me repeat this. We don't know. If someone is making claims about what happens to the female brain during the menopause, they're basing it on cross-sectional studies. What does that mean? That means I'm comparing a group of postmenopausal women to a group of perimenopausal women to a group of premenopausal women. That is not state-of-the-art menopause. We need to follow me, Pauline Maki, when I'm premenopause, then measure my brain when I'm perimenopausal, and then measure my brain when I'm postmenopausal. We do not have that study. So if anyone is making claims that we should be doing something to support the female brain because we know what happens to the female brain at menopause, they are drawing on data that is highly limited scientifically. Now, thankfully, I happen to be running what I think is the world's largest neuroimaging study to tell us what's happening to the female brain, but it's going to take a while. Why? Because I've got to follow hundreds of women from the time they're premenopausal to postmenopausal, right? So my message for your listeners and for providers who are listening here is the state of the science of what happens to the brain in menopause is that we have a lot of hypotheses, but we do not know.
We have a long way to go, don't we? It is a
We
very, very
do.
difficult state we're living in. You mentioned mood there as well. So getting on to,
Yes.
before I get onto that though, I had the random question. And the random question about this was, I was speaking to one of the very lovely doctors the other day who said to me, I was out working in a menopause group with a lot of people who do sign language. And they were saying basically that they may forget the words that they were looking for, but they never forgot their signs.
I love this.
I know. My thought was,
I love this.
Motor learning as opposed to some part
Yes.
of the
Yes. Well, I'll tell you what's interesting. Oh, I'm going to geek out for a moment here. Thank you for this. We have 5 very, very high quality longitudinal studies that followed large groups of women from the time they were through the perimenopause and into the post. And all of them, except one, show a decline in verbal memory in the perimenopause. All of them were reliable. The one that didn't is from Taiwan, where language is pictorial.
Oh, interesting.
So,
yeah.
and I have,
and China.
And I've said, I think it's because pictorial language is represented differently in the brain. And we know it is. So now you're telling me about sign language. And there is something about verbal. Does it shock anybody to hear that women are more facile verbally? If we speak more rapidly, we use grammar properly, we begin to speak earlier, we are more verbally fluent. If I tell me all the animals you can think of, if you're a female, you'll tell me more animals than if you were male. So yeah, it's interesting that you tell me this about sign language, because it is not, you'll hear people say, oh, it's all my cognitive abilities. It isn't. I mean, people studied the cognitive abilities. Oh, you're here, it's higher order cognitive functions. Higher order cognitive functions in these longitudinal studies did not change. It was memory and attention and learning. That's what changed. And it's very real for women. It's what you and I are doing right now, right? I'm speaking words to you. Maybe you're encoding them. Maybe you'll recall them later. That's very germane to our ability to function, isn't it? Right? Yeah. So it's not to minimize at all. It's just to say it isn't this global thing. But yes, but you mentioned the mood issues. We do know from longitudinal studies that follow women from the pre to the peri to the post that their perimenopause is a window of vulnerability, both for the onset of new major depressive disorder and for elevated depressive symptoms that don't quite meet the definition of clinical depression. Most women who develop depression in the perimenopause are women who had a prior depression. The large majority, but there is a subset of women for whom the withdrawal of estrogen, if it's at the postpartum, if it's at the perimenopause, if it's at the end of the menstrual cycle, triggers anxiety, triggers depression. And we're beginning to nail down in the brain exactly what's taking place in those women. It's not the majority of women. And my mood can be, I can be snappy because of hormonal fluctuations in the perimenopause. I can be snappy because I'm not sleeping. You know, there's a lot of reasons that our mood and our disposition can change. It's not just the direct effects of estrogen on brain systems that underlie depressive symptoms.
Are there, I mean, you mentioned postpartum depression and things like that. I mean, there are a couple of things that come out of this is that here in the UK anyway, they say that that antidepressants shouldn't be offered as first line for people developing new onset mood issues. So, but often they are still offered those. Are there, for clinicians and for the women themselves, basically, how do you know if your depression is a traditional clinical depression or if it's hormone related? And if yeah, well, basically, how do you tell the difference?
Yeah. Let's first go back to the antidepressants as the first line of treatment. So we just talked about new onset or getting clinical depression in the perimenopause, and I just told you that most women who have depression during the perimenopause are women with a history of depression. What that means is that's a recurrence of a pre-existing disorder. And for those women, you want to love the one you're with and use whatever helped them earlier in their life, whether it be an antidepressant or psychotherapy or a combination of the two, because it's a recurrence of the depression. Now, if they're also having a lot of hot flushes and they're not sleeping, of course we need to treat with that estrogen. But that's where antidepressants are, in fact, first-line therapy when it's a recurrence of a pre-existing disorder. Now, for those other women who are I haven't been depressed, but I've kind of been vulnerable at the end of my menstrual cycle, and maybe I had a rough time with one of my pregnancies or even in the postpartum. Those are the women who may benefit from hormone therapy, or the women whose symptoms are so severe that they haven't had a good night's sleep in forever, or their migraines are so terrible that they haven't had a good night's sleep in forever. Then we can talk about hormone therapy. Sometimes some women need both.
Yeah. I was going to mention the postpartum then. Is that sort of a signal then that if somebody had postpartum depression that perhaps they should probably try hormones rather than antidepressants in that case?
Yeah, the mechanism of action of those two depressions is similar. So it does suggest that. But you had also asked, what about depression in the menopause? Is it similar? And it is. It is similar, but it's challenging because the symptoms, sleep, fatigue, those are all symptoms of the menopause, and they're symptoms of depression, right? So you kind of need to assess both the menopause symptoms and the depressive symptoms in order to make a proper diagnosis. But it presents slightly differently. It can present with more irritability. So the depression can be more of an irritability kind of phenotype, but it depends on, the given women. And a lot of, we should share that a lot of people think when they think of depression, they think, oh, if I'm depressed, I have to feel sad or blue. But you can get a diagnosis of depression without that symptom, which surprises many, many people. You can get it if really what's happening to you is you're just not finding interest in things. You can't get pleasure out of your daily activities. So the social activities that used to make you happy no longer do. Your hobbies no longer make you happy. Your work doesn't give you satisfaction. You just don't have pleasure. That anhedonia can be a prominent feature of perimenopausal depression. And so we need to think not just about feelings of blues and sadness, but also just, I'm not engaging in my life. I'm not getting, that kind of pleasure from it.
And I'm guessing you're going to say we don't know when I ask this question, but do we know why some women are more predisposed to this sort of form of anhedonia or mood or panic attacks or anxiety, and why some aren't? Have we got any idea of which parts of the brain are controlling that and where
Yes.
the things are firing off?
Yes, we are getting closer to this, and it involves some of the metabolites of progesterone. We think that it involves allopregnanolone, which you might recognize as the treatment for postpartum depression. We increase allopregnanolone. And so some of the breakdown products of our hormones are really critical in helping us to maintain our anxiety. And by some models, um, chronic stress dysregulates the ability of these areas of the brain, particularly a brain area called the BNST, to do what it needs to do to help us regulate our moods. And we need, if you will, more equilibrium within that system in order to restore our ability to respond to stressors in our daily lives in a manner that helps us to manage our stress.
That makes perfect sense. Yeah, I'm sitting there before me. I'm going through and I'm ticking all of these boxes in my brain. I'm thinking, yes, yes. The other things that are good for mood and depression, which also tend to upset some people when they're mentioned, is you mentioned CBT before for insomnia,
Yes.
but CBT for mood and depression, and
Yes.
I have done it for anxiety, and I think it's a great thing. I've been trying to teach my husband actually how to do it as well, because it just teaches you a different way of thinking. But some people get very
Yes.
upset and think you're just telling me it's all in my mind and it's patronizing, but it's not, is it? Can you explain how CBT works and
Sure.
why for this?
Yeah, right. So thoughts are powerful things. Thoughts are powerful things. And what happens as we go through our lives is we tend to go down the same thought path. So if we sense a critique in the world, instead of saying objectively, oh, that's interesting, that critique came from there, but somebody else said something that would have, just said, well, maybe that critique isn't real, right? That's kind of a logical way, but we hear that and we're like, oh, I'm not holding it together. I can't manage my career. I can't handle my daughter's needs at the same time. I'm never going to get out of this. And we go down these well-worn thought patterns. We have these ruts, these very nice paths in our brain that we continue to dig in when we engage in these habitual thoughts. And what CBT does is it teaches us to pay attention. What is that chain of thinking that's leading to your negative experiences? Let's figure those out together. So they'll talk a little bit, try to figure out what they are. And it's a magical thing when they tell. I don't know if you've had this experience, but I remember when I was in therapy, the therapist said something and I was like, oh, you're good. Because I didn't see that way that my brain was thinking. I didn't realize that my thought pattern was completely illogical and very self-negative. And, it never occurred to me to question the way that I was thinking. So it was very helpful to have somebody say, now, the next time you start to go down that negative thinking path, I want you to think differently here. So you actually do rewire your brain in therapy. As much as you rewire your brain when you take an antidepressant, therapy increases the extent to which our emotional centers of the brain and our emotion regulation centers of the brain talk to one another. We see this in neuroimaging studies. It's a thing of beauty. Therapy is very powerful. The other thing that therapy does is it says, you got to do something, girl. You got to get up. You got to get motivated. You have to activate behaviorally. And to bring this down to everyday world, we've all had times where you felt like, I'm not going to enjoy going out and seeing my friends. I'm just not going to do it. But we rally somehow. We go out and we're glad we did it, right? So it's just doing those things that are hard, just getting out there and socializing and activating behaviorally. Those two components, really dampening down the negative thinking and then getting out there and being active can be very powerful.
Yeah, I think it should actually be taught in schools. I think it's almost like it's
I
a
agree.
Yeah, I think it's one of those things because it does, especially with this day of social media. I mean, if we think it's bad in the menopause sphere, imagine it for a 14-year-old. It must be a living hell. So
That's right.
Yeah, to be able to sort of, evaluate your thoughts and re-engage them and pass something off so you're not feeling so bad about yourself, I think it's something that should be taught in schools. That's
And it's a life skill, isn't it? It's like it's a habit. Like you learn how to process things in such a healthier manner. It's this very powerful toolkit that you come out of therapy with. And unlike an antidepressant, when you withdraw from an antidepressant, it's not going to help you anymore, right?
no, but
CBT skills are lifelong. Mm-hmm.
yeah, the life
Yeah.
skill, absolutely. Going back to the brain imaging for a second, there
Mhm.
was, you mentioned that before, somebody's come with a question saying that Lisa Mosconi says in her book that our cognition issues bounce back post-menopause. Are you saying that that's inaccurate? I didn't get that, but
So for some women it does, for some it doesn't. So I published it's in the literature, a study of 441 women followed for 8 years longitudinally, the kind of study that you want. And they were poor women of color in the United States, and they didn't bounce back.
do we know?
Their cognitive problems continued. We don't know why. It's something we're continuing to study. And in Neil Epperson's Penovarian aging study, she found that the declines in verbal learning bounced back, but not the declines in recall. So there's no uniform signal in the literature, in the prospective longitudinal studies that show that it bounces back universally for everyone. And my hypothesis is that it's not bouncing back for the women whose symptoms are not treated.
That would
Because those
make
hot flashes are still triggering, the sleep and the memory problems.
Yeah, I think from memory, what she did say did recover was the energy, the mitochondria, the ATP in the brain that we compensated.
There is no longitudinal study in women following them from the pre to peri to postmenopause to test the hypothesis of a bioenergetic shift in the female brain.
Which of course leads me to my next question, and that is, given if somebody gave you all the money in the world to do all of this research, what's your first pick to do, apart from what you're doing
I
already?
think I'm fortunate that I've just gotten a big NIH grant. I think Rebecca Thurston and I are going to get another big one to do our dream studies. So we're kind of there. But the question about hormone therapy that I want to know is, does hormone therapy improve memory in women who are symptomatic? Now, 80% of women are symptomatic, right? But we need women who are symptomatic feel that their memory is better when they're on hormone therapy. Our research ties vasomotor symptoms to memory problems, so it stands to reason. But standing to reason isn't enough. That's not enough in medicine. It doesn't mean we wouldn't treat their hot flashes. Of course we could, but what it means is that we can't claim that the hormone therapy is benefiting the memory objectively. So that's the study that I still would like to do. But we're fortunate in that we're going to have enough longitudinal neuroimaging data to really answer these questions about what's happening to the female brain. But women need answers. And the second area of research that we need to prioritize is what works and what doesn't, recognizing that even if we determine what works and what doesn't, the third study is, how do we get women the messaging so that they can understand what's, if you will, true versus what's just chatter.
Yeah, and therein lies the big challenge. And one of the big pieces that I know that hearts are not necessarily your direct area, but one of the big things that is now growing rapidly is statins don't work in women.
Yeah.
What do we know about that?
I'm going to quote Ta-Nehisi Coates. I'm not an expert, and so I'm not the right person to answer that question.
Fair enough. It's a big one that's gaining a lot of traction.
It is. It
Yeah.
is.
Yeah. We have a very, very long way to go.
We do know that heart health is brain health, though. And I
Yeah.
want to make sure our audience understands that, maintaining a healthy blood pressure level, maintaining healthy lipid levels as we age is evidence-based for decreasing your risk of Alzheimer's disease. It really helps, especially the hypertension. And so you want those regular checkups. And it stands to reason that menopause-associated changes in heart health will relate to menopause-associated changes in brain health. They don't appear to within, say, 5 years of the final menstrual period, but later in life, they may very well. And those are the kinds of questions that we need answers to.
Yeah. In terms of encouraging, I mean, you're actually quite lucky in the States at the moment because you've got, I think, Jill Biden managed to get quite a big bill through with a lot of people to make sure that there was a bit of extra focus on menopause over this.
Yeah, she visited my lab.
Oh, did she? Oh, well done.
Yeah, yeah.
We haven't been quite so lucky this side of the pond.
Yeah.
What do you do to make sure that, you know, the businesses, that farmer who benefit from this, and the governments
Yes.
who will find that the economy is better if women are kept in a workplace, if nothing else? What can we do to encourage them to put their hands into their pockets and do more research?
Yes, it's an exciting time for policy. We have a bill right now in the United States, which is a bipartisan bill. So menopause doesn't care if you're conservative or liberal or somewhere in the center. It's going to affect your well-being. And so we're very fortunate that we've got a bipartisan group of women together that are pushing this bill through to mandate training of our healthcare providers, to share best practices among different government agencies, to suggest the policies that you just mentioned for businesses. It's critical that everybody comes together. We actually look to the UK for best practices in menopause workplace policy, and we're getting some more of those in the United States. I was just at the World Trade Center for the World Economic Forum meeting on global women's health, which was adjacent to the United Nations meeting. And someone from Nestle told me, oh, Pauline, we just enacted a menopause policy globally at Nestle. So I think it's changing, you know, and that's great. But yes, we were fortunate that the First Lady took this on, and that I happened to be in the White House when I think for the first time menopause was mentioned in an executive order. So there you go. We said the word, it was said in the White House, and now it's in an executive order. So I think we're at a tipping point with all of this, which is important because we do need agencies that do not stand to profit from the messaging, if you will, to be delivering objective messages.
Yeah, absolutely. Well, I hope that we get to that point at some stage in the future. Can I thank you so very much for coming on? Really appreciate it. And hopefully—
Thank you for having me.
My pleasure. Hopefully we shall speak again sometime in the not too distant future. But just before are you going to Melbourne? I mean, I'm sure that you—
Yes,
probably—
I am.
this
Yes,
conference.
I am. Yep,
Oh,
giving
that's
a couple of talks there. Yes.
excellent. Well, I hope that it goes well in my original homeland.
Oh, I love Melbourne. Yep.
Yay! I'm not actually from Melbourne, but Australia general. I'm just going
Okay.
a big picture. But there you go. So look, thank you again, and I shall end that now. Take care.
Thank you. Be well.